Hi, welcome to the Move Muse Podcast. I'm your host, Kristen, physical therapist and founder of Moveology Physical Therapy and Wellness. I invite you to pull up a chair, sip on your favorite drink, and join me in real conversations around movement, health, business, and loving life. Hi, welcome back to another episode of the Move Muse Podcast. I have another guest on today, Dr. Loupe. She is a pelvic floor physical therapist, and we initially connected through our husbands and then our shared love of golf and physical therapy and helping women feel strong and confident in their bodies. So I asked her to come on today to discuss a little bit about endometriosis, and I'm so excited to dive in and learn all of the ins and outs of the nuances around the diagnosis of endometriosis. So thanks for coming on, Allie.
Yes, I'm super excited to be here. Thank you for having me.
We always do, or I always try to do, a What's in My Cup. So today we stopped at Tea Top in Carrollton. I've got a peach green tea.
And I have a vanilla matcha latte. So good, iced.
Yay! All right. So tell me a little bit, and my listeners, about yourself, Allie.
Okay, well, I have been a doctor of physical therapy since 2013, so for a lot of years. And I have been in pelvic health that entire time. I learned about pelvic health when I was in PT school. So I didn't go into PT school knowing that I wanted to do pelvic health. It was something I discovered early on, and I have just been running full force at it ever since then. So I'm very, very, very passionate about all things pelvic health, women's health, pregnancy, birth, menopause, all the things that come with pelvic health. But I'm also a wife and a mom to two amazing girls. And I'm originally from Minnesota, but we moved to Texas, and I'm loving Texas. It's been so great here. DFW has been a really good move for our family. So
awesome. Yeah. That is great. So I know that you work for Genesis Physical Therapy. That's local here in DFW with quite a number of locations throughout DFW.
Yes.
Kind of what has your role been like at Genesis, and what type of patients do you typically see?
Yeah. So we have multiple locations. Like you mentioned, I work in our Addison clinic, and I have a role as both a therapist and a director. So I'm a mentor over our team, and I also help to oversee some of our other clinics. But the primary patient population I see is women's pelvic health issues. But I also do treat men as well. Men can have pelvic health issues. Everybody with a pelvis can have pelvic health issues, and everyone has a pelvis, hopefully. But I see everything from trying to conceive and women in their young 20s with period issues, endo stuff, like we're probably going to talk about in a few minutes, all the way to pregnancy. I also am a birth doula, and so I get to see people during pregnancy, but also I'm there to support them in labor and birth, which is just so wild and an amazing part of my job. Postpartum, I also work with women in perimenopause, menopause. So throughout the life stages, I don't see pediatric patients personally, but we have people on our team who see peds for potty training and constipation and bedwetting and all of that kind of stuff. So that's a whole nother realm of pelvic floor issues. But yeah, I see women across the lifespan for all this kind of stuff. So, I guess I could tell you a little more about those diagnoses too, like bladder dysfunction, bowel dysfunction, pain with sex, hip pain, back pain, especially, we'll probably get into this in a little while, but especially those hip and back pain issues that haven't been resolved with your traditional kind of therapies or treatments. Oh my gosh, prolapse. I mean, the list is endless. There's so many things related to pelvic health. So.
It is really crazy because when I was in physical therapy school over 20 years ago, pelvic floor therapy was never really talked about. It wasn't discussed. And so it later became kind of this emerging niche in physical therapy. And it's really crazy just in my practice how many patients I've seen that I realized, okay, they need to actually get in with a specialist and see and have some pelvic floor physical therapy. And that's kind of what brought on the endometriosis discussion, is that I actually had a friend reach out to me. She is not local to the DFW area, but she had reached out. She'd been having some chronic hip and back pain. She had been to a number of physical therapists and chiropractors, neurologists, naturopaths. She had a number of injections. She wasn't getting relief from the pain. And of course, not being local, it's really hard when you have hip and back pain to really guide someone in what may be the issue. But she probably dealt with this for about 2 years before finally getting in to see a pelvic floor physical therapist, and immediately started having relief of this pain that she'd been dealing with and people were just telling her to deal with for 2 years. So that kind of sparked kind of the interest. And then as well, I had a colleague who herself is an experienced orthopedic physical therapist that was having some hip and back pain and was starting to see another colleague for her physical therapy. Went through about a year of just kind of your standard orthopedic physical therapy. And it was about a year in that she had the diagnosis as well of endometriosis. Wow. And she is a very experienced orthopedic physical therapist. So I realized just how much it is out there and kind of being dismissed or not being recognized probably as a diagnosis amongst even like the medical doctors, gynecologists, as well as your primary care physicians, orthopedics and neurologists that patients are going to. And so that's why I wanted to kind of get you on today to talk a little bit more about that.
Amazing.
So kind of, can you just give a brief description of what endometriosis is?
Totally. So endometriosis it's a complex and systemic disease that involves tissue that's similar to endometrial tissue of the uterus growing outside of the uterus. And so it can grow in typically areas around the abdomen and pelvis, but there's been other studies that have found endometrial tissue or this endometrial-like tissue in other areas of the body, like the diaphragm and even the extremities or the brain. But that tissue growing outside in those other areas becomes a problem because it causes adhesions and it can restrict blood flow. It can cause a lot of pain. It can get the nervous system involved. It's systemic, like I said, and really complex. And there's oftentimes a lot of other diagnoses that are overlapping with it as well, which is part of why it makes it so complicated and such an individualized experience for each person who has endometriosis.
Yes. Yeah. I think that's kind of what I've noticed is that it is more kind of a pain referral pattern with the nerves and then kind of tightness throughout the pelvic floor and the pelvis and everything as well. That's kind of creating some of the orthopedic issues that is being recognized by patients and other medical professionals, that's what they're trying to treat instead of the underlying endometriosis kind of situation. Is there a common age that most women are diagnosed or begin to kind of experience symptoms?
This is such a good question. So the first kind of part to that question is that, and this has been the experience for both of the people you mentioned leading up to this, is that oftentimes it takes years for women to receive this diagnosis. And I don't know this number exactly off the top of my head, but I want to say the last time I saw statistics for this, it was, I think, like 11 to 14 providers before they actually received a diagnosis. Hopefully that number is coming down and they only have to see 1 or 2 providers before that happens, or, a couple of providers. We can talk more about how it's diagnosed in a little while, but it takes a really long time. And so I think women can experience these symptoms as early as their pre-period time frame, all the way through those preteen, teenage, early 20-something years. I think most women are probably diagnosed sometime in their 20s or 30s, but that does not mean that's when it starts. It's probably been going on and building over years and years and years, maybe decades. But there is a lot of new cases that are being seen in women who are in their 40s, 50s, 60s, even postmenopausal, which is, it's not new. It's not that it hasn't been existing. It's just that it's been dismissed, and these women haven't been getting the answers and help. So when I said decades, it might have been 4 or 5 decades before they've gotten answers. And now we're talking about it more, and more providers are helping to spot the symptoms and get them the care they need, but there's still a huge gap to fill.
What are some of the early kind of signs or symptoms of endometriosis?
So one of the things, again, that makes it like complex and unique is that can really present so differently from person to person. But I would say the like most common ones I hear and the things that are like perking up like red flags in my brain when I'm taking a patient's history is a history of heavy periods, irregular periods, debilitating pain with their periods. Like periods might be uncomfortable and like not a fun time of the month, but they should never cause you to miss work or school because you're in debilitating pain or fatigue or headaches or throwing up or whatever. So people who are experiencing that debilitating level of symptoms, a lot of GI issues and bloating, digestive issues, constipation, rectal pain. A really unique one, but really common, is belly button pain. I see this a lot, and it's something that I think people just think it's weird, and so sometimes they might not even mention it to their provider. Or same thing with rectal pain. Like, are they comfortable even mentioning it to their provider? And is their provider going to pay attention to them? So those are some of the like ones that I see that kind of make me start thinking like, oh, there might be something more going on here than.
It's interesting because I think just in general, I mean, at least for my generation growing up, I think it's just something that you dealt with. Nobody really talked about what was normal or abnormal type symptoms, and everybody has different symptoms. And so I think maybe there's probably a lot of women that are just like, oh, I just have horrible periods times of the month. It's just what it is, you know, and they dismiss it unless it becomes kind of something that's more glaring and more painful, you know, to the point that they're needing to kind of figure out something more. They can't cope. Yes, exactly. Yeah.
And even then, to that point, like, I can't tell you how many times I've talked with like a friend or a patient and they've like, you know, shared, because I'm the person that everybody shares TMI stuff with. Love it. There's nothing that's actually TMI in my life, but they'll share with me like their debilitating period symptoms, and I bring up like, hey, has anybody ever talked to you about endometriosis, or have you ever considered this? And even then they're like, oh, well, it's normal. Periods are supposed to be terrible. My mom had this, my sister had this, my grandma had this, and it's like, well, maybe it's not normal. It's common, but it's not normal.
Yeah. And I think that's kind of the thing, is that your friends and probably your patients feel comfortable enough with you and trust you so that they can kind of share a little bit more than someone that they don't know, or they're just meeting for the first time. Right. Yeah.
Totally.
So kind of, I mean, my experience has been seeing more of the musculoskeletal type symptoms that come along. So like what I have basically noticed and kind of been more alert to is this back pain and hip pain that's just not getting better with traditional type physical therapy addressing, you know, back, hip, core issues. So kind of, are there other musculoskeletal type systems that come up?
Yeah, I think those are the main ones from an orthopedic perspective, but I would say it, you know, it can impact other areas. Like if the diaphragm or the rib cage or upper abdominal area is affected, you might see changes in how the rib cage is moving, and so that could cause shoulder pain. Or even jaw pain. There is a direct connection between our jaw and our pelvis and our pelvic floor muscles. And so when there's a lot of tension and pain in that area of our body, we also start to tense up in our jaw. And so jaw pain, TMJ is a really big one, something I screen for in all of my pelvic patients, but especially my endo girlies. And then even things in like the foot and ankle, simply because when we make impact with the ground, we have a whole kinetic chain reaction that happens up through our foot, our ankle, our knee, our hip, our pelvis, and then our spine. And there are movements and force absorption and everything that needs to happen at each joint. And so sometimes when there's something going on up top, it's going to refer down, or oftentimes from the ground up as well. And then when we see people moving in pain patterns where they're guarded, they're afraid to bend, they're holding tension because they're uncomfortable all the time, or they don't want to look uncomfortable, so they're forcing themselves out of that. Their movements are limited, and I think that's a lot of times where we see, especially chronically over time, some limitations in like lumbar and hip areas. And so it presents like an orthopedic diagnosis, and orthopedic therapy probably helps a little bit, but then it comes back, or especially if it's cyclical, right? Because there's a hormonal component to all of this as well. So if they're still experiencing a period, there might be cyclical symptoms that happen.
Excellent. Yeah. I know that we can't like diagnose as, physical therapists, and there's not really a cure for endometriosis per se that we would be treating for. But how have you identified, I mean, I guess you've explained quite a bit, but how have you identified treating a patient that's not coming to you necessarily even for a pelvic floor physical therapy or necessarily having already had a diagnosis of endometriosis? How are you have you identified issues and that?
Yeah, no, there's a lot to that question and I can answer all of it.
I think you as I'm asking that, I'm like, you covered quite a bit of that.
I can go deeper.
Okay.
I can always go deeper.
All right.
So I love this. Okay, so like I said earlier, when I'm like taking a subjective history, and sometimes it's the first visit because I get a lot of information on the first visit. Like we go places you don't imagine you're going to go with your PT with conversation. Yeah. But those red flags start to pop up to me. And so I might start doing some of the things or recommending some of the recommendations that I would do with somebody who has endometriosis, even though this person might not be yet diagnosed, or they might think they maybe have endo, but they haven't received an official diagnosis, which we should talk more about that in a second. But so I might start to see some of these like red flags and bring up the conversation, but also shift my treatment plan to kind of address that, because a lot of the things that we're addressing to treat whatever their symptoms are also going to help with the management and coping of endometriosis. Yeah. And so I don't know if that helped to answer your question.
Yeah, I think that's just as our role as physical therapists, and especially, you with the pelvic floor physical therapy aspect to it. I think that's kind of our role, is that we are recognizing symptoms, we're helping patients to manage the symptoms, and then some of the underlying like guarding issues or, you can go into kind of the lengthening of the pelvic floor, where a lot of people are trying to strengthen, where I've heard there's a big thing.
Definitely talk about this.
There's all of these roads and avenues that you can kind of go down. But I think that you're right, is that it's kind of looking at kind of some of the symptoms and then some of the compensatory patterns that are starting to happen is where we come into play, or especially more you come into play with that.
Totally. Okay, wait, can we talk about
I was wondering about that. Yes.
Pelvic floor?
Yes.
Okay, so a lot of times, this is true not just for endometriosis, but for all of pelvic health, and really anybody with pelvis, right? So our pelvic floor muscles, we should even talk about what the pelvic floor is for a second. Our pelvic floor muscles sit in our pelvis, and they are a support system for our pelvic organs, but they're also a huge component of our core. So our core is not just our abs, it's our pelvic floor, our diaphragm, our back muscles, all working together to create this canister of core support and stability for our body. Our pelvic floor muscles are really important for sexual function, bladder function, bowel function. They help to support our lymphatic and our circulatory system in helping to pump fluid up and through our pelvis. There's a lot of nerves and structures that run through our pelvis, and our pelvic floor muscles are not functioning great. It's going to have a big impact on all of those areas. And so a lot of times when people, this is where I wanted to get to, a lot of times when people hear about pelvic floor therapy or anything regarding the pelvic floor, immediately they think of Kegels, which is a voluntary contraction of the pelvic floor where you squeeze your pelvic floor muscles for a certain amount of seconds and then you should let them go. Kegels are like the 1940s recommendation of what pelvic floor therapy should be, and they're extremely outdated. Now, it's important for a person to know how to contract and relax their pelvic floor muscles, and we usually go through all of that in, our first couple of visits of pelvic floor therapy if it's necessary. But I'm never sending patients home with instructions to contract their pelvic floor muscles. Okay. So much of what our pelvic floor does is anticipatory in responding to the demands of whatever we're doing in life. And so while we do have voluntary control over our pelvic floor muscles, we need our pelvic floor to be more reactive. And so most of what we do in pelvic floor therapy is so much more whole body movement focused, so that we're not just getting these tight pelvic floor muscles. And women with endo already have a lot of tension. They have all these extra, adhesions and lesions in their body. Right. And so if we're constantly just tensing up, most likely their pain's probably going to get worse. So don't you Kegels. That's the message of the story.
Yes. And that is kind of, I mean, again, my knowledge base has definitely expanded, but I think that is kind of the message that is out there and what people understand for, oh, well, if I'm going to go to pelvic floor physical therapist, they're just going to teach me how to do these Kegels. And there's so much more to pelvic floor physical therapy. Yeah.
I always say pelvic floor therapy is whole body therapy. There is not a single person where I'm not assessing their entire body. Like I said, jaw, feet, everything.
That is crazy. That is really crazy. So you had mentioned earlier that you would come back to this, and I think this next question kind of segues a little bit with it. Women that think they have endometriosis but have not been diagnosed. Yes. What would you kind of wish women that were experiencing these symptoms knew, or that were feeling that that's something that they have?
Definitely. Okay, so if you suspect that you have endometriosis, or you just have a lot of the symptoms and that resonates with you that we talked about earlier, the first thing to know is that the only true way to diagnose at this point in time, to diagnose endometriosis is by surgery. And so a lot of women they're not ready to jump into a surgery just for the diagnosis, especially because just doing the surgery there's not a cure for endo. And so doing the surgery isn't necessarily going to cure it. A lot of women do go into surgery, and the gold standard for surgery for endometriosis is endometriosis excision. And there is endo excision specialists that do that. Now, there are a lot of like OBGYNs or other providers who will say that they do like endometriosis surgery where they're going in and doing ablations or hysterectomies, but those actually don't usually have a positive or huge impact on endometriosis, especially because removing the like organs like a hysterectomy, the endo is other places. It's not necessarily just in their pelvic organs. And so if it's in their bowels, doing hysterectomy might not actually solve their issues. Wow. And then the ablation is where they just go in and like burn the tissue, but endometriosis continues to grow. And that's the tricky part of it. And even with excision, it can still grow back, but we've seen the best results with endometrial excision versus ablation, definitely over hysterectomy. Now, there are times when a hysterectomy is warranted with endometriosis. So not to say that that's like not okay to do, but it's not the cure at all. And I think a lot of women misunderstand that.
Yes. Well, it kind of leads into my next kind of comment is that I did ask listeners if they had any questions. And so this one wasn't really a question as much as kind of what you're talking about, I think would be helpful just to this person, but I think to more listeners that are honestly suffering in this way. Because I feel like so many are just quietly just waiting. And I have this whole thing now that I've gotten more into women's health about the hysterectomy aspect. But anyway, so talking about kind of this specific episode, she had mentioned being interested, great, wanting to kind of learn a little bit more. But she was just saying that she's just kind of waiting the time out until she could finally just have a hysterectomy. The pain is intense. She's already having hormone changes that are difficult to deal with. And so she's just waiting to have the hysterectomy. And so what would you say? I mean, obviously that you're saying that that's not even necessarily a cure for this. So what do you say to women that's in their head, that that's what they're waiting for while they're suffering through? Is there something that they should be more advocating for themselves or learning about?
Yes, 100%. I would first say that there's so much that you can do to help take care of your body and help to manage those symptoms while you are waiting for whatever that next step is. And again, if the hysterectomy is what's warranted, then that makes sense, but it's not the cure. And so if that's the first thing your doctor is recommending, my opinion would to get a second opinion, especially with somebody who's an endo specialist. Which I can give some recommendations at the end of our podcast.
That would be great. Yeah.
But there's so much hope. And so find a pelvic floor therapist who is experienced in treating the whole body. So vet them with questions. Do they give Kegels? Because there are still pelvic floor therapists who are like stuck on Kegels. Hopefully we can get that over with by the end of 2026. But I think it's going to take some more time than that. But find a pelvic floor therapist, because there's so many things we can do from a place of education and manually working on the body. I do a lot of manual therapy on all areas, the abdomen, the hips, back, the pelvic floor. Pelvic floor therapy often involves an internal assessment and treatment, but it doesn't have to. And it's always before a lot of education and informed decision making between you and your provider. But I do a lot of internal work because there's just so much tension in there. There's also a lot of things that you can do if you haven't already tried in regards to like diet and lifestyle changes. And while I know sometimes that can get overwhelming to hear because those things are hard to change, especially if you've changed them and you haven't felt a difference. But playing around with trying to reduce inflammation, take care of your sleep hygiene, really focusing on decreasing like cortisol levels, which is so hard. Like we're trying to do that too.
Yes. That is, I mean, the same philosophy that I'm working with on all of my patients is the hydration, the sleep, the inflammation, the stress levels, all of that beyond just your basic exercise, manual therapy. You know, there's so much more that the body's reacting to. So
so just really like partnering with somebody who can come alongside you and help to give you some suggestions for where to start and also help to hold you accountable and to hold that vision for you to move forward so that you're not just holding it all yourself. Because sometimes people come into me and they just don't have any hope. And so I get to hold that for them a little while until they can start to take that hope and hold it for themselves.
That's amazing. Really cool. That is really awesome. Yeah.
Love it.
So I kind of had mentioned that as far as within physical therapy school, I think pelvic floor is now like maybe a day discussion in PT school.
Yeah, it's gotten a little bit better.
But it's still not taught. It is something that like Allie did, that you go into specializing after you've been out and treating and knowing that that's kind of the area that you want to specialize and treat in. It is a very specific specialization for physical therapists. So that being said, I hate to really generalize this and dumb this down, but I feel like there are a ton of orthopedic physical therapists that are out there that are treating some of the symptoms that may be related to not even just endometriosis, but a lot of pelvic floor dysfunction issues. And that's the resulting kind of symptoms that kind of show up. And I would hate to say, but I think they treat and they're not getting better and they're like, well, just, go home, keep trying those exercises, give it some more time. It'll get there. Is there anything that, one, I don't think that should be kind of the method. I think you should be finding people in your fields that you can refer out to and, kind of get that, more specialized knowledge if that's something that you feel like they need. But is there anything that you wish that orthopedic PTs would see or know when to say, hey, maybe we need a little bit more in-depth in pelvic floor here?
Yes. I think this is such an important topic because I think you're right. There's just like a gap. We didn't learn it in PT school. And you have to work really hard to find the right sources of education for it. So it's not because your orthopedic PT didn't learn it or didn't want to learn it. They just weren't taught it. And that's true in regards to pelvic health in all of the medical field, your OBs, everything. But I would say, one, I would first encourage my orthopedic PTs that you actually probably know and can do a lot more for the pelvic floor than you realize you can. There are some really great courses that really tie in ortho and pelvic health without having to take the whole deep dive into becoming a pelvic health therapist. I can share some of those with Kristen for you so she can list them in.
I will definitely go down that track. I've actually been looking at that because I listened and I follow a ton of different pelvic floor physical therapists because this has just been so fascinating of just wanting to make sure that I'm not missing something. And so there's a lot of different kind of screening tools that are trying to kind of pop up for those of us that are not specialized to kind of be able to kind of recognize. But yes, I would love to learn more information for the non-pelvic floor.
So I think just like being able to educate yourself from a place of like, what can you do within the ortho world and realize how much of what you're already doing is probably making a positive impact. That's why sometimes your patients do get a little bit better. Sometimes it's just not getting all the way down to the root cause. So you're like on the right track. And then the second thing I would say is in regards to endo specifically is to not be afraid to ask your patients especially your female patients, about their period history. I know it can be hard sometimes to ask about intimacy. I talk about sex all the time with my patients. And so ask them, you don't have to get as deep as me, but say, does this affect your intimate life? And you can tell them, you don't have to tell me details, but whatever you're willing to share me, and maybe I can connect you with the right resources, but be curious. Yeah. And if they share with you, you might be able to glean a little bit more information. And then the last thing I would say is connect yourself with a pelvic floor therapist in your community of trusted providers, so that when you do think you have somebody with more going on, you can collaborate and co-treat. And that doesn't mean you're giving your patient up to somebody else. I can't tell you how many orthopedic PTs we share patients, especially because I work in a private cash-based practice. And so I don't always see my patients like a typical ortho PT is seeing them like a couple of times a week or even weekly. Sometimes I see my patients every other week or once a month. And so I really love collabing with an ortho PT where they can be working with them, maybe that twice a week frequency or weekly frequency to work on some of the more orthopedic based things. And then I can dive deeper into the pelvic health thing because I have somebody who's working beside me to collaborate. So connect yourself with somebody in your community so that you can have a good referral source. And I guarantee you they will refer back to you, because as much as I love the orthopedic stuff, I love having somebody like co-treat with me. No, that is great. Yes. And four eyes. I don't know. It's better than 2 eyes. 2 eyes are better than one.
No, that's really great. I love all of this. There is just touching so brief. This is basically just touching so briefly on one small diagnosis in like the pelvic floor physical therapy. I know you have way more knowledge and treat a whole lot more beyond just endometriosis. Is there anything that we haven't talked about that you want to share or anything?
Well, here, I'll share. This is a really specific example, but I actually had an endo patient that I've been working with this morning, right before I came here. And I shared with her that I was going on this podcast. And I asked her, I said, what do you want the world to know? Or what do you want other patients or other women, I should not refer to them as patients, other women to know that might be also experiencing endometriosis symptoms? And the thing that she said, and this is a really specific example, but I'm carrying on her information, is that she wished somebody would have told her sooner about taking care of her nervous system. And one of the things specifically for her was that she was doing all these HIIT workouts because that was what was accessible to her. And that was raising her cortisol levels and creating a lot of extra inflammation. And so while she thought she was doing something really good for her body, it just wasn't what her body needed. And that's really specific. But I think the moral of the story is recognize how your nervous system is connected to all of this, because it's a systemic thing. So
that's so great that she wanted to contribute and have
she's
something
an amazing
to.
Person.
I
see so many wonderful women.
That is. I'm in awe of kind of everything that you do, and just Allie's also a birth doula. She kind of had mentioned that, and so just kind of following, we were trying to get together a couple of times, and she's on call. That is it's just amazing how you've expanded outside of just what I think many people's perception of what physical therapy is. And that is available here locally in DFW and stuff like that. So,
well, thank you.
Definitely. So I always kind of end the podcast with one small move, either something that my listeners can do throughout the week or to think about. Do you have anything that you would love to show?
I will. I'll show you one of my favorite exercises. And truly anybody can benefit from this exercise. So it's 2 parts. So I'm going to teach you the breathing part first while we're sitting, and then I'll stand up to show y'all the standing part. The first part of it is diaphragmatic breathing. And I feel like everybody has heard and talked about diaphragmatic breathing, but to be honest, nobody is doing it well. So we want to
I'm going to move over and then you can get kind of centered.
Perfect. When we breathe into our diaphragm, what diaphragmatic breathing is expansion and contraction through our diaphragm, our breathing muscle. A lot of people think that it means belly expansion or seeing their belly move up and down. But what we really want is 360-degree movement at our rib cage. And so I like to have people put their hands on their ribs like this, or you can hug across this way. If you're with a physical therapist, you can grab a TheraBand and put a band around your rib cage to have that 360 pressure. But you want to work on breathing breathing in through your nose into the sides of your rib cage, and then out through your nose and your mouth. And you should feel that lateral expansion and also some posterior expansion of your rib cage. A lot of people just get forward movement of their rib cage, and you see a lot of movement up in their chest or that belly breathing, but we truly want it to be three-dimensional. So diaphragmatic breathing is a piece of this exercise, and you have to do the diaphragmatic breathing part right in order to get the full benefits.
Perfect.
So the second part is a standing exercise. So I'm going to have Kristen angle the camera down for a second. Hopefully you can see my shoes. I am going to turn my feet in so that my toes are facing each other. I know this looks funny and it's not a position we do very often, but that's kind of the point. We live life in a lot of external rotation, and that puts a lot of compression through our lower back, hips, and pelvis. And so by turning our feet in, we're bringing our hips into hip internal rotation, and that actually puts a nice stretch on many of our deeper hip muscles and our pelvic floor muscles. And so from here, you can stand at either like a countertop or the edge of your bed with your feet turned in and your knees kind of angled inward. And then you're going to hinge at your hips. So you want to make sure, if you want to move the screen up just a tiny bit. There you go. Yeah. You know what my feet are doing now. So you're going to hinge at the hips. So I'm not rounding through my back. I'm truly hinging. I'm leading the movement with my butt. And then I'm just going to rest my arms on the table or the surface. From here, I'm going to do my diaphragmatic breathing while I shift towards my butt or towards my back pocket on each side, breathing into the back of my rib cage. And this is just going to get, like I said, that really nice stretch and mobility through all those deep hip and pelvic floor muscles. So a favorite of mine for hip, low back pain that's related to the pelvis.
I'm going to tie this back a little bit into golf because, well, how do I go about this?
I'm so excited.
I had seen, I actually had just heard somebody talking about this hip internal rotation and lengthening of the pelvic floor, all of it together with back pain and specifically with golfers. And so a lot of the golfers that I treat are, it's my back, give me the back exercises, blah, 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 blah. And I'm like, no, actually you don't have the hip internal rotation that you're needing on your swing. And so your back is compensating. And so I've always kind of just worked on making that hip internal rotation, external rotation kind of even out a little bit better. But I had just heard from someone that there are a lot of male golfers that have low back pain, that have tight hip internal rotation, but on top of that have this issue, tight pelvic floor.
Yes. Oh my gosh, we need to come back and do an extra episode on
just
golf-related things.
Yes.
But I can't tell you how many times I have had patients who are golfers and they come back and they're like, so is there any chance that this would help my swing? I'm like 100% because if you don't have hip internal rotation, your swing is missing it.
Yeah.
So
that is awesome that you showed that, because I literally had just seen that actually this morning.
I love
that. I was listening to another podcast and they were talking about it and I was like, oh man, look at this.
Yes, of course we would bring it back to
that's awesome. That is so great. Okay. So where can people find you if they want to get in touch with you, follow you, get more information, anything like that?
Definitely. The best place to find me is on Instagram. You can follow 2 different accounts. The first one is Genesis PT and Wellness. And the second one is my personal account, which is prettypelvis.dpt.
I'll put that, I'll put the actual links and stuff like that in show notes and everything. Yeah.
Cool. And then you can find us on our website, genesisptandwellness.com. But yeah, those are the places that I'm most active. And then if you're following our Genesis page, you'll get a chance to see all of our other therapists, and they share some really amazing content.
Yes.
So yeah.
Genesis PT is really great about having their individual therapists kind of take control with social media and do a lot of their own kind of individual education and stuff like that.
You see our personalities come out on our individual accounts.
Yeah, so for sure. Well, thank you so much for coming on. This is great.
Thank
and then hopefully we can get together again another time and see if there's some other fun topics to go down.
100%.
Yeah.
Thank
Excellent.
you.
Bye guys. See you next time.